I'd like to introduce our next speaker. It's Dr. Michael Barnett. He trained in medical oncology at St. Bartholomew's Hospital in London, England, before joining the Leukemia and Bone Marrow Transplant Program of British Columbia in 1986. He served as director from 1996 to 2001, and after spending 2 years back in London as professor of transplantation oncology, he returned back to Vancouver in 2003 as the head of hematology. Dr. Barnett spends his professional time overseeing activities of the division and treating patients with hematological malignancies. He has a particular interest in the myeloid leukemias. Please welcome Dr. Michael Barnett.
Good afternoon. Thank you very much for that, the introduction. So I think actually these talks are actually fairly difficult because it's obviously this type of audience I think is actually more receptive to the talk and actually has many more questions than some of the audiences we're used to. Anyway, we should welcome that. So this is the title of my talk. I should point out that the division, the UBC division of hematology, like all the other divisions, has a component at Vancouver General Hospital and a component at St. Paul's Hospital. And then there are other members of the division, I'll mention some of them later, who work in the laboratory. So it's customary with all talks nowadays to have some disclosures. So here are my disclosures. The first is I'm very pleased to be invited to give these talks. The second is looking around the room. I'm even more delighted, no, actually I shouldn't say even more delighted, but I'm equally delighted to see a number of individuals in Manchester United shirts. That is red shirts, and I take this as an omen for their game against their fierce rivals Manchester City tomorrow afternoon. Second, I'm not Heather Leach, and that's my second disclosure. And the reason I say that is that Heather has become really one of our experts in this area of iron overload. And in the last 3 to 5 years has done an absolutely tremendous job in actually being our lead person in Vancouver, and I would say in British Columbia. And I think she's played an important role in developing the field. She also gets numerous invitations to meetings, and this weekend I think she's in talking at St. John's, and that's why I'm here, because I'm sure if she were here in Vancouver she would have been invited and accepted the invitation to talk to you this afternoon. As you heard from the introduction, not only am I not Heather Leach, I'm not even a hematologist. But you'll have to bear with me. You've seen this sort of slide many times. This is my version of the sort of introductory slide to marrow and blood. And I've just shown on here the sites where the marrow is active. So as you know, the marrow is the spongy material on the inside of bone, and as you can see, it's sort of particularly active in the pelvis. And in the spine and the ribs. And if we want to take a sample of marrow, and I'm sure a number of you in the audience have had a marrow sampled and perhaps don't want that to be repeated, but we take it from the pelvis under local anesthetic. We can also take it from the sternum as well, but do that infrequently. As you've heard earlier today, the key cells, the stem cells, reside in the marrow, although as I'll touch on later, they can be mobilized into the blood, and that has practical implications. This is not really what you see when you look down a standard microscope, but this is an electron microscope, but it's quite beautiful, I think. With the red cells, you can see here the smaller cells, the purple ones are the platelets, and the other cells are different types of white cells. So here, in this screen, you can see basically the major blood types The red cells, of course, have the hemoglobin, and the heme part, as we'll talk about, is where the iron is, and this is involved, of course, in transporting oxygen and carbon dioxide, absolutely critical. The white cells are involved in the defense of invading organisms and microorganisms, and as you've heard, the platelets are involved with prevention of bleeding and stopping bleeding. So this is obviously a hugely important system. You've seen various variations on this theme, but in terms of my topic, marrow failure, there are obviously the diseases we're interested in can all cause marrow failure. Myelodysplastic syndrome, typically looking down the microscope, has too many cells. They're hypercellular, but they don't seem to be capable of producing normal blood counts. There is another form of myelodysplastic syndrome where it's actually not hyper but hypocellular, and sometimes it's difficult to distinguish hypocellular myelodysplastic syndrome from aplastic anemia. And typically with aplastic anemia, when patients present with low counts, that is marrow failure, that is because the marrow is empty. So, and then the third disease that we're talking about is PNH, or paroxysmal nocturnal hemoglobinuria. This is a fairly rare disease. I don't know if there are any patients in the audience with this disease, but for those that don't know much about it, when patients present with this disease, they are anemic, usually because of breakdown of red cells, some hemolysis. They also get problems with thrombosis, but there is also a problem with marrow stem cells, and so some degree of marrow failure as well. And as Dr. Neville pointed out, there is a relationship between those three diseases: myelodysplastic syndrome, aplastic anemia, and PNH. So in terms of management, I've actually just realized now why the pointer doesn't work, because I'm pressing next, and that's why the slide jumped forward. So you would have been far better getting Heather Leach, I think. So this, I've just put on here, and I think it's worthwhile, you get asked to talk about one particular area, which in this case is going to be an issue related to supportive care. But of course, there are many other areas in terms of management of patients with these diseases that cause marrow failure. And I'm going to repeat this slide and show you again in my second talk. So I'm just going to deal very briefly with the first four. I'm going to be talking in detail about supportive care, but perhaps I could just say, general measures for someone. These are also important. Someone who has a low platelet count, we would tell them to avoid aspirin or Advil or similar drugs which affect platelet function. You can imagine if the platelet count is low and then you affect the function of that low number of platelets, then you can be in quite big trouble from bleeding. And also, of course, and I'm sure all of you have heard this, that patients with a low platelet count, to never let anyone give an intramuscular injection, because that can result in quite significant bleeding. So there are important general measures. Quite a number of my patients are taking alternative therapy. I don't have a problem with that at all, as long as I know what it is and can make sure that there are no untoward interactions with the treatment that I'm actually giving. So to supportive care, which is the main item on the agenda for me at least, and supportive care takes a number of forms. For marrow failure, obviously transfusions of both blood and platelets, antimicrobials, very important, antibacterials, antivirals, antifungals are all part and parcel of the management of patients with marrow failure. Growth factors we're not going to talk about, but there is some role for GCSF, erythropoietin, and as Tom Neville said, some other agents maybe will come along for stimulating platelet production. And then at the bottom here, we've got iron chelation, which is the topic of my talk. So blood transfusion is I would say, the major component of supportive supportive care. And maybe in this bag of blood, if you just remember a couple of figures here, in terms of iron content, the content of iron in this bag of blood is somewhere between 200 and 250 milligrams. And as you'll see, as the talk progresses, you'll see that is a significant amount of iron in a bag of blood, which is given to the patient every time we give a blood transfusion. Related to that, I suppose, within the body, the total iron in the body, about 2/3 of it is in the red cells. So that puts all of this into context. So the rest of the talk is about iron. And I'm going to, at the beginning, at the end of the talk, I will describe two iconic figures in the 20th century and their role related to iron. So the first one is, you of a certain generation will recognize Popeye. I don't think he's around too much anymore. There are numerous quotes. If you Google Popeye, and you come up with all sorts of things, but the quote that I wanted was this one, which is, "I'm strong to the finish because I eat my spinach. I'm Popeye the Sailor Man." So you remember the cartoon. He got his strength from spinach, and of course, spinach is a great source of iron. The other sources of iron in the diet being meat, a lot in for example, liver, as well as greens and eggs. Dairy products will also have iron as well. The total amount of iron in a Western diet is about 10 to 15 milligrams, but only a fraction of that is absorbed. So we only absorb about 1 to 2 milligrams of iron per day. But shown here, spinach is a very good source of iron. Just as an aside, as I was trying to get the picture from Google, I came across a whole stream of correspondence about how do you actually write down Popeye's laugh, if you can remember it. He has a very distinctive laugh, and I thought, gosh, these people have nothing better to do. But then I spent the next 15 minutes trying to work out what I thought it was. So this is what I think it is. But those of you who remember Popeye, maybe you could think about his laugh and how you would write it down, and whether or not this is accurate. So what about iron overload? I think the important factor here is there is no physiological mechanism to eliminate excess of iron from the body. And so the iron absorption, which is from the small bowel in the duodenum, has to be carefully regulated to avoid accumulation. So for a standard individual in their diet, as I've said, they will take in on a daily basis 1 to 2 milligrams of iron a day. And per day, they will excrete 1 to 2 milligrams of iron in cells and some blood loss and some menstrual loss. So that is the sort of tight balance. And it has to be tight, as I say, because there is no mechanism to eliminate excess iron. So in a situation with iron overload can occur, as you can see, for two reasons. One, excessive absorption, and that's not the topic of this talk. And then the second would be blood transfusions, because I've shown you just a couple of slides back that the bag of blood has 200 to 250 milligrams of iron in it. That's a lot of iron. And the problem is that that excess iron accumulates in the reticuloendothelial system, but when the RES gets overloaded, when there's about 10 to 15 grams of iron, then it goes into normal tissue. And that's when it causes damage. And the major problems relate if the iron is in the heart, the liver, and we get failure of those organs, or in the endocrine system. And there may be problems, for example, with the thyroid or sugar metabolism. So that is a sort of simple overview of the situation with iron. And we can assess iron overload in a particular individual. So if we're looking at the iron stores, we can just take a blood sample and do serum ferritin, which is quite a good way of looking. The best way is probably to do a liver biopsy and look at the total iron in the liver. But this is not an easy procedure, of course, in patients who have low blood counts and would be avoided. And so we wouldn't do too many liver biopsies to look for the total amount of iron in the body. There is a new technique, magnetic resonance imaging with a T2 star, which you may or may not have heard of, which we can do and look at the liver. And that is a fairly good way. It was thought also that it would be useful to look at the heart as well, but it doesn't seem as useful looking at the heart with this technique in that there has to be many transfusions before you actually detect it in the heart. Then the third line here, Dr. Leach actually gave me some instruction about this talk, and she told me that to actually appear to you as something other than an imposter, I would have to know what all of these things stand for. And of course I don't, so I wrote them down. And NTBI is non-transferrin bound iron, LPI is labile plasma iron, and ROS is reactive oxygen species. Now, if you are in Dr. Leach's league, this is the sort of terminology you use. Most of us are not, and we don't. So, tissue damage we can assess with standard assessment of heart, liver, and the endocrine system. So, how do we treat iron overload? First of all, what is the aim? Well, the aim is to, I suppose, is to prevent or reverse established end organ dysfunction. So this is a situation where there's so much iron in the body, it's gone out of the reticuloendothelial system and is now in major organs and causing problems. If you're a great enthusiast, you may argue that treating iron overload may influence the course of the underlying disease. I'll come on and talk about that. So as well as the first aim, that is to remove iron so that you're improving major organ function, there is a possibility that if you remove iron effectively, you will also influence the course of the underlying disease, for example, myelodysplastic syndrome or aplastic anemia. I've mentioned, just for completeness, phlebotomy. So you can actually remove blood from patients, and we do it for certain diseases where, for example, patients are making too many red cells, one of the myeloproliferative disorders. We treat some of those patients with phlebotomy where on a periodic basis we will remove a bag of blood as a way of getting rid of red cells. And you can also do the same thing to get rid of iron. Of course, this is not applicable to most of the patients we're talking about this afternoon because they have problems with producing cells, and this would compromise that situation. But for example, after a transplant where the marrow is now from the donor and making good number of cells, if that patient is iron overloaded, then we have on occasions actually taken blood from patients to reduce the iron. But this phlebotomy is not really applicable to most of this conversation. Iron chelation, I think this has been touched on already, but there are three agents. The first one has been around for quite a long time. It's got a very short half-life, and it can't be given orally. So this medication is given either by subcutaneous or intravenous infusion, and it's really quite inconvenient. I'm sure there will be some members of the audience who have had this treatment, and so the treatment is usually given as an infusion over 8 to 12 hours, 5 days a week, something like that. And it's given at home, but it's still quite an inconvenience. But it is an effective way of getting rid of iron. With this drug, the iron is removed from the body by the urinary and fecal route. We do have to watch for any problems with the eye or hearing on this medication. The other two are oral agents. Deferiprone, as far as I know, we can actually get it for our patients, but in general it's not available in North America. Its half-life is longer. It can be given orally 3 times a day. The excretion of the iron is through the urinary path. There are some rare events. Agranulocytosis can occur, but in general, this treatment is fairly well tolerated. The problem being the inconvenience. And then the third drug, this is the new drug called trade name Xjade, which is oral. Its half-life is such that it can be given just once daily. It is also an effective medication. The side effects in general, it's fairly well tolerated. Some patients do get some gastrointestinal upset, and in about a third of patients there is some renal impairment. So we have medication to try and get rid of iron. In a situation where we've got a patient with iron overload, we want to mobilize the iron and actually get rid of it. Heather Leach has very kindly given me some slides, and she actually gave me about 75. So I selected 5, but I don't want you to tell her that. But I think the 5 that I selected are quite good. Not that the rest isn't good. And actually, if you ever heard her talk, she would have already presented 50 of them by now if she were here. So I wanted to look, though, if in patients who receive iron chelation, is there an effect on survival in the low-risk myelodysplastic syndrome? This is where the information is available. And also, is there a potential role of this treatment in patients with higher-risk myelodysplastic syndrome? So I'm going to just, in about 5 minutes, go through that. The third point here is related to transplantation. It's been known for quite a long time that those patients who have a transplant, who have high levels of iron, tend to get more complications of the transplant, more transplant-related toxicity. So a couple of groups, some of the pediatric groups, have looked to see if they carry out iron chelation before the transplant, does that improve outcome? And there are at least a couple of reports suggesting that if you do that, perhaps you can improve the outcome by reducing toxicity of the transplant by getting rid of iron before you actually take a patient through a transplant procedures. But I would say and caution you that those studies are all retrospective, and there isn't really a proper control arm. And that is true of quite a number of the studies that I'm going to present to you. So this slide is from a paper that Heather published in 2008. And I would say there are quite a number of studies like this one. I've just chosen Heather's because I am more familiar with her work than anyone else's, and again, to make the point that she's doing a terrific job in terms of being our lead person in regard to iron overload and its management. And what she did was she went back through the records of patients at St. Paul's Hospital, and it goes back quite a way to 1981 to 2006. Got a significant number of patients, but you can see that the first problem, because it goes back so far, it makes it very difficult to come up with the sort of comparison that she has done. And what she did was she just looked at patients with lower risk myelodysplastic syndrome and just had a look, see whether they did or did not receive iron chelation, and then drew a survival plot. And I think you've seen quite a few of these today. Basically, this axis shows the cumulative percent of the total patients surviving, and then this is, along the bottom axis, the time from diagnosis. And the point I just want to make is that the top curve there looks like, and statistically is a much better survival plot. This is the patients who received chelation, than the bottom curve, which is a group of patients who did not receive chelation. And the enthusiasts, I suppose, would leap forward and say, this obviously shows that iron chelation results in better survival for patients with lower risk myelodysplastic syndrome. The cynics would say it doesn't have to have anything to do with the iron chelation, because if you think about it, it's just this group did receive iron chelation, but it may be totally spurious, and there may be many other reasons why the survival of this group is better. Having said that, there are a number of centers who've published similar results. You may say, well, there's such a huge difference here between the curves, but I would say to you, over 20 years, I've seen this sort of presentation before, and one example would be a number of years ago, women with breast cancer were treated with high-dose chemotherapy and a transplant because it was thought that this would be good treatment, and it had been good treatment for leukemia lymphoma. In actual fact, the original studies, like this one, the early ones, which really didn't have a proper control arm, looked similarly effective as this. But once the randomized study was done, the difference went away, and it was shown that this was not an effective treatment. So I don't know at the moment whether this does mean that iron chelation results in better survival. I would like it to mean that, but I don't know. And anyway, there are a number of other studies like this. So the second area, which is very interesting, and again, this is from Heather's group, and there are other cases like this reported. Sorry, this is quite a complicated slide, but an important one. This is information on one patient, a 76-year-old man who presented with myelodysplastic syndrome, again, lower risk. And when he presented here, you can see what's being tracked here is the hemoglobin in yellow there, and the ferritin, which is red or orange. I can't actually see. So after presentation, he started to require blood transfusions. As you can see, 3 units of blood about every 4 weeks. And he was offered iron chelation at some stage, but did not decide to accept on the grounds of the inconvenience. But when the oral agent became available, so that's ICT started, when XJade was available, it was offered to him, he accepted and tolerated it very well. And you can actually see within a short time, he became free of blood transfusions because he's actually started to make hemoglobin. And you can see that this is now, his marrow is making hemoglobin as it sort of takes off. Sorry, the pointer's not working so well now. But from the middle of the slide going, as you look at it from left to right, to the top right-hand corner, that's the hemoglobin going up. And at the same time, the fall there of the ferritin. So I think this is an important observation that actually, if you give iron chelation, you see in some patients you can influence the blood counts favorably. Yes. No, I don't think. Not under my care, but I don't think the patient was receiving any agent that could have influenced the situation. So a number of other groups have shown similar cases, and so there's actually a study called the EPIC study, which has brought together a number of cases, and at least in abstract they presented recently, the probability of this happening in patients, for example, with lower risk myelodysplastic syndrome getting iron chelation, maybe between 15 and 20% will get some improvement in either hemoglobin or the neutrophil count or the platelet count. So what we actually really need, what's going to be important, is to do a proper randomized study. This is a study which is sponsored by Novartis, where patients with lower risk myelodysplastic syndrome are randomized to receive either the XJADE or they get a placebo, and they're randomized 2-to-1 so that twice as many patients will get the XJADE as the placebo. And in this way, we will get the answer to a number of questions. The primary endpoint is going to be event-free survival, so survival and any significant events in the heart and the liver, and then the secondary outcomes are going to be survival, numbers of transfusions, progression to acute myeloid leukemia, and effect on the thyroid and sugar metabolism, so the endocrine effect. So if this study is conducted, if we can get the patients onto it, it's going to answer a number of important questions. This is now you can see from this NTBI, LPI, and ROS that Heather told me is so important. It's also thought that accumulation of these with the reactive oxygen species may, and this is really from animal experimentation rather than any proof in humans, that it could influence the underlying disease. And actually, if you've got iron overload, perhaps it could make it more likely that the disease will transform from myelodysplastic syndrome into acute myeloid leukemia. There is no real evidence to support this, but this is a hypothesis at the present time. So what is a sensible iron chelation? Again, I got this slide from Heather. I mean, just as one comment, as you can see, personal communication from this chap at the bottom here. It's got to be a sorry reflection of your social life if your personal communications are related to iron overload. But there you are. But Heather is very keen. So this chap thinks that transfusion dependency may be 20 to, if a patient has had 20 to 30 units of blood, the ferritin is between 1,000, greater than 1,000, up to 2,000. If you look at the risk score, it says yes, definitely, maybe that patient will benefit if in the low risk category, but has not committed himself in terms of the higher risk. And that's, I think, the higher risk group will also require a randomized study. Where does that leave us? Well, I don't know, actually. I mean, having been through all of this information, I think a lot of it is very interesting, and I would very much like to think that iron chelation will not only improve organ function, which has been affected by iron overload, but also perhaps influence the course of the disease. But I don't know that, and I don't think this information tells us at the moment. The human condition is such that some physicians are going to be wildly excited about this, and some physicians are going to be cynical about it. And really the only answer is to do proper control studies. So I said I would finish with the other side to the iron story. So this is Baroness Thatcher, who was known as the Iron Lady, of course. And you can see, although Popeye was very straightforward, he attributed his strength to spinach. Not a bit of it with Baroness Thatcher. Being powerful is like being a lady. If you have to tell people you are, you aren't. And I suppose we shouldn't be surprised by this quote, because before she was Baroness, and actually before she was Prime Minister, she was, I think, Minister of Education. And during that time, she removed free milk from the school system. And at that time, because of that, by the socialists, she was referred to as Snatcher Thatcher. So I can see that if someone would take the milk away, they probably would take the spinach away as well. So I've got a number of people to acknowledge. Jessica has started to prepare my talks, and for the first time in 20 years, I had my arm twisted into including color as opposed to black and white. But she stood her ground and made me do it. Heather Leach, despite my jokes, is absolutely terrific, and she's a great credit to the division in terms of the work she's doing with iron overload. Ed Conway is director of the Centre for Blood Research on campus, and I had a number of conversations with him about blood substitutes which are being prepared there. And my colleagues, all of whom, great group at Vancouver General, St. Paul's, UBC, and I've mentioned our science goes on, the benign hematology at the Center for Blood Research and the malignant hematology at the Terry Fox Lab. And here are some of their websites for thrombosis, leukemia BMT, St. Paul's, the Center for Blood Research, and the Terry Fox. Thank you very much.